Good morning. Today we are discussing Etomidate. Introduction and Pharmacology. Etomidate is a central nervous system depressant classified as a hypnotic agent. It is a short-acting, non-barbiturate intravenous anesthetic that provides a rapid induction of hypnosis. Its unique pharmacological profile makes it a mainstay in the anesthesiologist's and emergency physician's armamentarium. Etomidate's primary mechanism of action is its potentiation of the inhibitory effects of gamma-aminobutyric acid, or GABA, at the GABA-A receptor. By binding to a specific site on this receptor, Etomidate enhances the influx of chloride ions into neurons, which leads to hyperpolarization and a decrease in neuronal excitability. This results in profound sedation, hypnosis, and amnesia, which are the desired effects for anesthesia induction. A key distinguishing feature of Etomidate is its minimal impact on the cardiovascular system. Unlike many other induction agents, Etomidate does not significantly depress myocardial function, and it maintains cardiac output, heart rate, and blood pressure. This hemodynamic stability makes it an agent of choice for patients with compromised cardiovascular function, such as those with severe aortic stenosis, cardiomyopathy, or hemorrhagic shock. Clinical indications and applications. The primary clinical indication for Etomidate is the induction of general anesthesia. Its rapid onset and short duration of action make it highly effective for this purpose. The drug is particularly valuable in the setting of rapid sequence intubation, especially for patients who are hemodynamically unstable. In a patient with significant trauma or severe sepsis who may be hypotensive, Etomidate allows for a quick and smooth induction without the risk of further precipitating hypotension, which is a common adverse effect of other induction agents like propofol. While it provides excellent hypnotic effects, Etomidate lacks analgesic properties, meaning it does not relieve pain. Therefore, for painful procedures, it must be used in conjunction with a separate analgesic agent, such as an opioid. Its favorable cerebral hemodynamic profile, which includes a reduction in cerebral blood flow and intracranial pressure, also makes it a suitable choice for patients with intracranial pathology, provided that hypercapnia is avoided. Dosing, administration, and cautions. Etomidate is administered as a single intravenous bolus dose. The standard adult induction dose is 0.3 milligrams per kilogram injected over a period of 30 to 60 seconds. Dosage must be carefully individualized based on the patient's weight, age, and clinical condition. Elderly patients or those with reduced cardiac output may require a lower dose to avoid excessive drug effect. The drug is typically supplied in a formulation containing propylene glycol, which can cause significant pain on injection. This discomfort can be minimized by injecting the drug into a larger, more proximal vein or by preceding the Etomidate injection with a small dose of intravenous lidocaine. A very important caution regarding Etomidate is its propensity to cause involuntary muscle movements or myoclonus, which can be quite pronounced. Premedication with an opioid or a benzodiazepine can help to reduce the incidence and severity of this effect. Controversies and adrenocortical suppression. The most significant and widely debated controversy surrounding Etomidate is its effect on the adrenal axis. Etomidate potently inhibits 11B hydroxylase, an enzyme essential for the synthesis of cortisol and aldosterone in the adrenal cortex. A single induction dose can lead to a temporary but clinically significant suppression of cortisol production lasting several hours, which far outlasts its hypnotic effect. While the clinical significance of this transient suppression in healthy individuals is minimal, it becomes a major concern in critically ill patients, such as those with sepsis, who rely on an intact adrenal stress response to maintain hemodynamic stability and survive their illness. The debate centers on whether this drug-induced adrenal suppression contributes to increased mortality in these vulnerable patient populations. While Etomidate's hemodynamic stability is attractive for induction in a septic patient, the potential for contributing to a state of relative adrenal insufficiency has led many clinicians to avoid its use in sepsis, favoring alternative agents like ketamine or propofol, despite their potential for hemodynamic compromise. The ongoing clinical debate and conflicting evidence highlight the need for careful patient selection and a thorough understanding of Etomidate's unique pharmacological profile. Thank you for your attention. Please let me know if you have any questions.